Good morning, everyone, and good afternoon, good evening, wherever you are, and welcome again. It's really wonderful to have you all here as we join the second session in our prioritization and optimization series. My name is Ramande Potentia, and I work with NISH, or the NITAG Support Hub, based at the University of Cape Town. And together we bring you this series, which is a collaboration between ourselves, together with WHO, HQ, AFRO, JSI, and development catalysts and other country partners to form the Choices Project. So our intention is to support you as NITAGs and your national immunization programs to strengthen the evidence-based decision-making process for introducing new vaccines and optimizing those already in your programs. So for session 1, which occurred on the 8th and 9th of October, we looked at why prioritization and optimization actually matter so much. We heard from our speakers and from you as our attendees how your immunization programs are facing more complex decisions, more vaccine options, tighter budgets, and growing expectations to actually show that there's value and impact to be made. And that's also why WHO and SAGE in 2025 encourage countries to use the NITAGs to lead this process of systematic and evidence-based decision-making in deciding which vaccines to introduce. So in terms of that really sets the context for what we covered. In terms of our key concepts that we covered in session 1, it was that of prioritization, which was really about planning ahead how we would choose and sequence new vaccines based on their impact and their feasibility in country. And the other was optimization, which was really about making the best use of what we already have available, but improving the way they're delivered, how they can be introduced in our schedules, for example, so that we have better efficiency and coverage. And today we also spoke then about some country examples using these principles, such as that from Ethiopia and from China. And I invite you, if you didn't manage to make the session, to follow the link in the chat, which is to the recording of session 1, so that we are able to just ground ourselves in these principles. But both P&O processes rely on the collaboration between the NITAGs and the EPIs, where we use tools like this NVI PST toolkit that we'll walk through today, and also the evidence to recommendation framework to make the process structured, transparent, and adaptable to our specific countries. So we hope today, as we move towards forward, really, that we just keep building on the foundation and apply more of these principles in practice. So let's together just dive in, see how we can use these frameworks to help us in our decision making. So just one moment for housekeeping is that you've probably noticed already that there is no translation service. Today is an English only webinar. So you are very welcome to attend the French webinar tomorrow if you require translation services. The participants will be muted during the webinar itself. And because we might have a little bit of a technical delay when we get to the question and answer session in unmuting, we really want to ask you to please put your questions into the Q&A box throughout the course of the talk this morning, so that we can go straight to answering those questions and optimize our time together. We also want to remind you that we can't do better if you don't tell us how to do better. So please fill in the session survey that you'll see on the QR code, and also that will appear later in the chat links. So I think with that, our session is 90 minutes and should end promptly at 1:30 p.m. And I'd invite Professor Greg Hussey to continue. Thank you very much.
Can you see my screen, Ramande?
I can see your screen, just not in presenter mode, Greg.
It should be in presenter mode now. Okay.
Super, thank you.
So let me first of all thank the organizers for the invitation to do this short presentation on vaccinology support for new vaccine introduction, prioritization, and optimization. My name is Gregory Hussey. I am the founding director of the Vaccines for Africa initiative based here at UCT and a member of the NISH team. Haddison Eposi will be doing the French presentation tomorrow. As VACFA, we have been involved in vaccinology training and support on the African continent for the past 21 years. And we believe that understanding vaccinology is vital for making recommendations on new vaccine introductions and immunization practices. This presentation will give participants at this workshop a brief insight into this discipline. And this is especially for those who may not be familiar with the subject. So vaccinology is a multidisciplinary field that covers various aspects of vaccine development and immunization practices, from discovery to delivery, or as some would say, from the bench to the bush, with the bush being a synonym for community. The definition that I prefer is that it involves scientific and strategic disciplines that guide the development, evaluation, and implementation of vaccines to protect public health. Now, vaccine introduction decisions require evidence from multiple scientific fields to ensure that vaccines are needed, that they're safe and effective, that they're economically viable, that they're impactful on morbidity and mortality, and that they're deliverable and equitable in the context of a community. While these disciplines are important individually, collectively they provide the evidence for new vaccine introduction, prioritization, and optimization. On this slide, I just briefly show the 8 important disciplines underpinning vaccinology. And I must add that this list is not exhaustive. I've also added a specific important question that each of these disciplines addresses. And note again that this is not the only question. So for example, in the context of epidemiology, we're trying to decide whether the vaccine is needed and what the impact it will have. In terms of biostatistics, what is the evidence really show? In terms of biotechnology, can we make the vaccine safe and at scale? In terms of immunology, does the vaccine actually work in the body? In terms of mathematical modeling, what will happen if we act or don't act? In terms of health economics, is the vaccine affordable? And is it the best use of resources? In terms of health systems, can we deliver it equitably and sustainably? And in terms of public health, how do we maximize population benefit? So as I said, these disciplines individually and collectively assist with decision-making. So on the next 8 slides, I'll go through each of the disciplines individually. I mentioned the major contribution of each discipline and highlight only 3 important examples. So for example, in terms of epidemiology, epidemiology helps us define the need. In terms of the specific issues, it quantifies disease burden and identifies populations at risk. It tracks disease trends and outbreak potential. It guides which diseases are most urgent for intervention. But remember, these are only 3 issues that the discipline of epidemiology addresses. There are numerous other issues that they address. So, for example, in the context of Africa, going back to rotavirus implementation, here's an example in terms of how epidemiology contributed to the introduction of rotavirus vaccine in Ghana, for example, publication from George Armour going back to 1994, justifying the high burden of rotavirus disease in Ghana. In terms of biostatistics, the discipline of statistics. It helps validate findings through statistical analysis of surveillance and clinical trials. It provides precision in terms of confidence intervals, p-values for policymakers, and it supports credible data-driven prioritization amongst other evidence. So, for example, here, looking at Kenya in the early noughties, statistical evidence confirmed HIV vaccine effectiveness, supporting the rollout. And I've given you a reference for that. In terms of biotechnology, again, in terms of biotechnology, we would like to ensure that we can make a vaccine safely and at scale. So biotechnology supports the development and refinement of vaccine platforms, improves stability, delivery methods, scalability, and ensures vaccine availability for low resource settings. And a very good example in terms of pediatric vaccines is the role that conjugate technology made in making the bacterial vaccines like Haemophilus influenza type B and pneumococcal conjugate vaccines suitable for infants. And there's a reference for you from Shabir Madi et al. Looking at the issue around vaccines to prevent bacterial infections. In terms of immunology, immunology plays an important role in terms of prioritization. It helps determine immune correlates of protection. It supports the development of doses and the need for boosters, and it helps to support schedules and so forth. And there's an example for you again from Kenya, looking at the issue of HPV. And as we know, many countries in Africa are now implementing single-dose HPV vaccine, and this follows the observational work that has been done in many countries previously, and the pivotal recent trial by Barnabas et al. Looking at a single dose of HPV vaccine in Kenya. Again, mathematical modeling. Here's an example from the HPV rollout in low middle income countries, showing how mathematical modeling can support decision making. I'm just running through these rest of these very quickly. Health economics. Here's an example of how economic models justified rotavirus vaccine adoption in low income countries. Here's an example in terms of the context of health systems, ensuring feasibility and readiness within countries, regions, districts, etc., etc. And this is an example from the African region, looking at pneumococcal vaccine rollout guided by health systems readiness and support. And then lastly, in the context of public health, here's an example of how school-based strategies promote the acceptance and uptake of HPV vaccines within young children between the ages of 8 to 10 years old. And this is a reference from our school-based program on implementing HPV vaccines in schools. So in summary, I know it's been a lot to take in over a short period of time. Vaccine decision-making is not the product of a single discipline, but it is the outcome of a multidisciplinary ecosystem. Each of those disciplines that I briefly mentioned answers a different question, from can we make it, will it work, should we invest in it, and how do we deliver? And together they ensure that vaccines are not only scientifically effective, but also socially acceptable, economically justifiable, and operationally feasible. So just to conclude, before I hand over to the next speaker, each discipline contributes distinctly, but also provides complementary evidence to the decision-making process. The integration ensures that vaccines are scientifically justified, economically viable, and socially acceptable. And this multidisciplinary approach drives effective vaccine prioritization and optimal introduction of new vaccines. So that's vaccinology in a nutshell. And if you haven't been to one of our vaccinology courses, please contact us and hopefully you will join us on a course in the near future. So I'm going to hand over to Kamal to take over and take the issue of prioritization, optimization further and to look at specific tools. Thanks, Kamal. I'll stop sharing.
Thank you very much, Greg. And let me project my slides. And what you presented is going to be very helpful for what I'm going to present. So I hope you can see my slides in presentation mode.
It's in presentation, thanks.
Excellent. Okay, so the idea today is to follow up on what we discussed last week and to move one step further into the prioritization discussion. And again, I'd like to thank all the colleagues from NISH, of course, from GSI, Choices, WHO, UNICEF, and others, as we are all working here to support countries to be able to do better decisions for their vaccination programs. So just to remind you, last time what we discussed is the prioritization. And just before I dig into this slide, I just want to remind you that what we said was that prioritization is about looking at the future. Which vaccine the country should consider potentially to introduce in the future, 5 years, 10 years. That's the prioritization. Then when a vaccine has been prioritized, then you need to look at this vaccine specifically, and the NITAG needs to make a recommendation, a specific recommendation regarding which schedule, which target population, which product to use. And that's when the NITAG decides about those are recommendations regarding introduction. And then you have the optimization phase, which is looking at what you already have in your immunization program and try to improve it, to optimize it. And it can be either by changing the schedule. Greg just mentioned, for example, HPV moving from 2 doses to 1. You can also decide to change the product itself, like for PCV, you can decide to move from 13 to 10, from 10 to 13. It depends on your context and the money you have. And it can be also looking at the different products that are on the market for the same vaccine. Like, should I go with one vaccine that is produced in a DCVMN country, in India, in China, in Indonesia, or should I take a product that is coming from a high-income country and the prices are not the same? So those discussions are optimization. And here today, we're going to go through the prioritization, but I still want to compare the different tools that are or will be available for you. Today, we're going to talk about the NVIPST, which is for now a tool that is focusing on the prioritization. But I want to still mention the others, and I want to give a bit more information about the others. Let's start with the optimization tool. The optimization tools are under development. WHO and UNICEF are working currently to develop tools that will help countries to look at their schedule and to make decisions regarding what can be changed for a better program. For example, the HPV moving from 2 doses to 1, the PCV changing product because they are cheaper, moving to the hexavalent to increase coverage. So all those kind of things. So those tools are under development, and WHO and UNICEF are going to come back to you soon with those tools. The other one I want to mention is the ETR. Many of you probably already heard about ETR, which is the evidence to recommendation. And that's the tool that you use in the NITAG to make a specific recommendation on a specific question. Typically, you can use this tool to make a recommendation regarding introduction of a vaccine. Let's say that you've done the prioritization last year and that you have identified a vaccine that should be introduced in 2026. So then you need the NITAG to look at all the data, all the product, and make a specific recommendation regarding this specific vaccine. Like if we decide to introduce PCV, we need to use that vaccine, PCV 13 or PCV 10. We need to focus on that kind of population. We need to do it nationally. All those kind of recommendations that the NITAG does, they do it using ETR, evidence recommendations. So I just want to make sure that you see the difference between ETR and NVI PST, the new vaccine introduction prioritization sequencing tool. So again, NVI PST is looking at 3 to 5 years or even more and decide which vaccines should be interesting for the country to introduce in the future. So you just go through, and we're going to go through the process. I'm going to explain the process, but it's just looking at many criteria to decide which vaccines should be considered in the future for the country based on the diseases, on the money, and all that. But then when you have done that, again, you have to speak specifically for a vaccine. And I'm repeating myself, but if you have identified in the prioritization the need to introduce a PCV vaccine, then you need at one point, if you said, for example, let's introduce it next year, you need then the NITAG to use ETR and to be able then to look at all the data to define precisely what are the recommendations for that specific vaccines, the target, the product, the type of vaccine, etc. So those are the two things that you use. Let's say that NVI-PST is the future and ETR is to look at a specific question. The two tools use the same kind of approach, which is called the MCDA, the multi-criteria decision analysis. And we're going to go into the detail to explain what it means. So let me go to a few questions, and I'd like to hear from you, colleagues. If you can raise your hand and tell me what you think is the response to those questions. So let's start with the first one. Does NVI-PST replace evidence to recommendation framework? So can I get somebody to respond to that? And I'm not sure I can see all the hands, but please, and no worries, we are just between us. There is no stupid response. Okay, I have Zenebu. Zenebu, go ahead. Zenebu, can you hear me? I don't know if we can, Ramonde, I don't know if we can give the floor to Zenebu. Yes, go ahead.
Okay, hello, this is Zainabu from the Mauritanian NITAG. I think that NVI-PST will not replace the ETR, but it will be kind of complementary.
Excellent. Thanks, Zenebu. That's correct. As I said, the ETR is really to look at one specific question at one moment, where the NVI-PST is to look in the future about the potential vaccines to be introduced. Let's move to the next question. The next question is when a NITAG should use ETR and when a NITAG should use NVI-PST. So anybody wants to try on that? Beverly, go ahead.
Okay, so the ETR is used to collect evidence to support a recommendation and to decide if the schedule should change or if the vaccine should change. So it's all evidence-based. And then the next step is the NVI-PST to decide exactly how to introduce it.
So not completely. Anybody else wants to try? Zenebu, go ahead again.
Thank you. I think for the ETR, it's once the NITAG receives a question from the Ministry of Health, and for the NVI, it will be once the national immunization strategy is changed or once there is a new immunization strategy.
So thanks, Zenebu. So yes, I would say that the ETR is really to respond to one specific question that NITAG is asked to provide a recommendation. It can be, should we introduce this vaccine? Yes, no. Should we change the schedule? Should we change products? So that's one question. Where the NVI-PST is to look at all the evidences to say, okay, in our country, those 2 or 3 vaccines are the most important ones that we should consider to introduce in the future. And we will go through the steps now, but that's the objective of the NVIPST. Let me go of the last question and I'll move on. Can I use the evidence that I collected during the NVIPST process for the ETI work? Because as I said, NVIPST, you look in the future and you say, okay, we should probably introduce those 2 or 3 vaccines in the future. And then the ETR will be to look specifically at this vaccine and say, okay, if we want to introduce this vaccine, which target, which product, which schedule we should use. Anybody wants to respond to that? I don't see any hand, so I'll go ahead. So indeed, you can use what you have collected for the NVIPST because some of the information you will see now, I'm going to show now, are also very useful for the ETR. So let me move on for the sake of time. So the NVIPST tool is this. The thing is that you want to see all the vaccines that are available, and we start on the left side of the slide. You have all the candidate vaccines. There are many vaccines on the market, many vaccines that you haven't yet introduced in your own country. So there are many. And you have first to do a pre-selection. You're not going to look at the hundreds of vaccines that are available. You're going to look at the vaccines that you already know that are of interest or maybe of interest in your country. I'm always taking the example of the Zona Shingrix, for example, vaccine. Many of the countries where we live, they're not going to consider those vaccines because they are for a very small part of the population and the burden of the disease of Zona is quite limited. So usually this is not a vaccine that we are considering in our countries because it's an expensive one. So you're going to select like maybe 5, 6 vaccines that you think may be of interest in your country. And then you're going to look for each of these vaccines. You're going to look different criteria to see if the vaccine is important for you and if it's feasible to introduce this vaccine in your schedule. For example, what is the burden of disease of the disease that will be protected against that vaccine? For example, I would like to compare RSV vaccine and I want to compare it with typhoid vaccine. And I'm going to look at the burden of disease of those 2 diseases. And I'm going to look at that and I'm going to say, oh, in my country, it's probably better to consider RSV when you look at the burden of disease because it's much more than the typhoid. It can be different from a country to another. So those are the criteria that you can use to look at the importance. The feasibility is to check. If I introduce this vaccine in my schedule, will it be easy or not? Like, is it costly? Is it fitting in my schedule so I don't have to add new visits to the medical doctor because it fits already in my schedule? Is it a vaccine that I can use in my cold chain? I don't need to expand my cold chain. So this is the feasibility. So you're going to compare the vaccine looking at all those criteria. And based on that, you're going to classify the vaccine as high priority, which are vaccines that are very important for your country because they will have a high impact on the health of your population. They may be easy to introduce in your schedule. So those are the vaccines that are high priority that you will recommend the country, the EPI program to consider in the future. You have medium priority vaccines that are also interesting, but less. So you may consider those vaccines in later, like after having introduced the high priority vaccine. And then you have the other vaccines that you're saying for us in our country, it's not a priority, so we should not consider them for the future. And then the last phase is to do scenarios. For example, in the first scenario, you say, okay, I'm just inventing. Next year, we should consider introducing RSV vaccine because we have a high burden of syncytial respiratory diseases. Then 2 years after, we should consider introducing malaria vaccine because we have some burden in our country. So you do scenarios like that for the future. And you can have several scenarios because, for example, you may say, oh, the vaccine that is for me the most important one is not available for me in the future because there is limited availability of vaccine on the market. So I do a second scenario where this vaccine, RSV, I will not introduce next year, but probably in 2 years when the vaccine will be available. So that's the NVI-PST process is really looking at all the vaccines that are available, using some criteria to see if those vaccines are important for your own population, for your own country, and then you prioritize them and you rank them, looking at which one is the most interesting for your population in your country. So you have to look at your data. So that's the idea of the process. So the process is done by the NITAG. The NITAG is the main driver for this process, and the NITAG will get support from the EPI manager to be able to do this process. But it's mainly done by the NITAG. And why the NITAG? Because the expertise in the NITAG is good and is broad. You have epidemiologists, you have clinicians, you have sometimes modelers, health economists, you have different kind of people. So the first step of this process is really to meet with the minister, with the director of health, to explain the process, to get their buy-in. So they will support the NITAG to do this work. Then you have a workshop with the NITAG to be able to discuss different things during this first workshop. First, looking at which vaccine we should consider. Let's ignore the vaccine that we know already we will not introduce in our program because, as I mentioned, the Zona vaccine is not important for our country. So this one you eliminate and you select just the few vaccines that you want to compare. Then you decide about the criteria that you want to use. Are you going to compare the burden of disease, the efficacy, the availability of the vaccine, the price of the vaccine, etc., etc. So you select which criteria you're going to use to compare the vaccines. Then you make a plan to decide who's going to collect the data, because you need to collect the data for each criteria. For example, burden of disease. What is the burden of disease of this disease, of this one and the other? So somebody needs to collect the data. You're going to do a plan to be able to do it in the future. And then you have a few months during which the EPI program, the NITAG Secretariat, and the NITAG members will collect the data to be able then to have a second workshop during which they're going to compare. Let's compare the burden of disease of RSV, typhoid, malaria, and others, all those vaccines that we haven't yet introduced, to see which one is going to have the more impact in our country. So that's the second workshop. And by doing that, you will compare the vaccine, and at the end, I'm going to show you using the NVI-PST tool, you will be able to say, okay, this one is the most important one, this one is the second, and here are the scenarios that we're going to put in place. And lastly, based on that, the NITAG will provide some recommendations to the EPI program, and those recommendations for future vaccines to be considered for introduction will be included in the National Immunization Strategy, the NIS, and also in discussion with the Ministry of Finance, with the donors, to be able to find the money to potentially introduce those vaccines in the future. So the process, I'm not going to go through the process now, but what I just explained, the different steps, there are 9 steps that you can use to do this process to be able to prioritize the vaccine. As I said, nine steps, 2 workshops, but the most important step is really the data collection, because you need to collect the data for the various criteria that I mentioned. And this is very important. And that's what is a bit time consuming, but without good evidence, your decisions will not be very good. So that's important to take the time to find all the data that you can use for the discussion during the second workshop. So this is what several countries have done the first workshop. They discussed first the timeline. Should we consider vaccine? And in this country, it was Niger, they said, let's consider 5 years and let's do the process again in 5 years. Then they looked at all the vaccines that were available on the market, and they decided to consider 6 vaccines, like the meningitis, the HPV, the measles and rubella, the typhoid, so they made a short list. And then they looked at all the criteria that they wanted to consider to compare the vaccines. And they came up with something around 10 criteria. You don't need too many criteria because then it's complicated to compare. And then they collected the data during 3 months, and then they came back for the second workshop. And in the second workshop, they went criteria by criteria and they compared the vaccines. Okay, and they came up with the ranking. The NVI-PST tool help you to have a table that summarizes the ranking For each criteria, the members of the NITAG voted which vaccine was the most impactful. And then they have this priority. You can see this table with colors that helps to prioritize. They have high priority vaccines, measles, rubella, hepatitis B, and hexavalent. And then they did the scenarios saying, first scenario, we introduce measles, rubella next year. Then the following year, hepatitis B, and the others we'll see after. So I had a few questions, and I know I'm a bit late in time, but I just want to go through those questions, and then we open the floor for questions. So first, can somebody tell me what are the 3 phases of the NVI-PST tool? Anybody wants to give it a shot? Again, no worries. It's just between us. There's no... Zeynep, I'm going to wait because you ask many questions. Let me ask if somebody else want to ask a question and respond to that question. Anybody? Please, colleagues, what are the 3 phases? Zeynep, I'll go back to you then, if nobody wants to respond to that
Okay,
question.
thank you.
Zeynep, go ahead.
The first phase is the pre-selection of vaccines, and then we will assess the feasibility and the importance of those vaccines. And the last phase is establishing the sequencing of recommendation, establishing
Excellent.
the different scenarios.
Excellent. And in the first phase, you pre-selecting the vaccine, but you're also deciding which criteria you want to use to compare them, because each country is going to use a subset of same criteria, like the burden of disease, the efficacy, the safety, but they also may use criteria that are not the same. Anybody wants to respond to the next question? But Zeynep already did for that one, so let me try somebody else. Who should be involved in the process? And I want somebody else than Zeynep. Please, colleagues. Richard, go ahead.
Hi everyone, Richard Lessels from the South African NAGI. So it should be the NITAG, but also the EPI manager or management, and you should have as diverse a range of people as possible. So clinicians, public health people, immunologists. So yeah, as wide a range as possible.
Thanks, Richard. Indeed, the NITAG is the main driver for the NVI-PST approach, the prioritization, but they need to have support from the Secretariat, which is usually the EPI manager and his team, because they need to be able to identify the data, to find the data, and to bring them back to the NITAG so they can compare the vaccine. Let me take an example of the feasibility criteria. If I introduce this vaccine compared to the other ones, which one will have the strongest impact on the cold chain? So those data can come only from the EPI program. So that's why they need to provide all that. So let me now go to the Q&A section and back to you, Ramonde, for the Q&A section.
It's actually Folake.
Folake, sorry, Folake.
Yes,
Folake,
that's fine. Kamel, thank you so much for such an extraordinary session, and also to Greg. We really had a rich overview in terms of the multidisciplinary approach to decision-making and effective prioritization and optimal introduction of new vaccines. Greg, thank you very much. Kamel, the overview of the framework for the NVI-PST really elaborated the key elements, the processes, and your questions were just a spark to get us thinking about how to use it. Thank you. I'm going to invite everyone to share any questions that they may have. We are looking through the Q&A box at the bottom of your screen, and you're also free to raise your hand. As you do that, my name is Folake Olainka, and I'm a consultant with JSI working on the Choices 2 project with the wonderful colleagues here, NISH, Development Catalyst, WHO, and others. So I'll be looking for your hands. If you would like to ask a question, we can unmute you. So please do raise up your hand.
Lucky, there is currently a question on the screen.
Wonderful. Thank you very much. We do have a question on the screen. And Kamel, I think this is a good one for you to speak to, looking at documentation on countries that NITAGs that have already adopted the NVI-PST framework.
So we have, for now, we don't have an article. We are working on an article. Several countries have done it. We have countries in Africa like DRC, Niger, we had Uganda, we have Ethiopia who have done the exercise. We have countries in Asia, and Dr. Akbar is with us, and he did it in Iran. So the idea is really to develop an article to do that. For now, I mean, we just have a generic presentation on what they've done and the lessons learned from that, because initially it was pilots conducted by those countries. But then, I mean, some countries now are doing it as a regular exercise. So no paper now, but very soon, hopefully.
Kamel, thank you very much for that. And I would second that I'm aware that there are some journal articles that are in the process of being published on this topic from the African region. So thank you. I'm looking for other questions, or if you would like to put up your hand. I do see a question in the chat here, and I can take that or draw your attention. Irena, thank you very much. What are the main sources of evidence for decision-making that can be used during data collection process? Kamel, I'm going to send that over to you once again.
Thank you, Folake, and thanks, Irina. So when the NITAG will do the first workshop, they will decide which criteria they want to use to compare the vaccines. Most of the time, they use some criteria that are well recognized by the community, like the burden of disease, like the efficacy of the vaccine, like the acceptability, like the safety of the vaccine. And sometimes they use other criteria that are the cost, the cost effectiveness, those kind of things. So based on the criteria, then the country needs to identify evidences. So evidences can be at different types. Most of the evidence are at national level, like the burden of disease. Only the country has those data. So you need to find those data, usually with the Ministry of Health. There are some data they can use. Some criteria, they come from global level, like the safety of the vaccine. It comes from clinical trials, from other countries that have introduced the vaccine. So we know what is the safety of the vaccine. And sometimes the data are not available at country level. So you need then to find a way of still having some evidence, because you need to make a decision. So you cannot just wait for the data to be available at country level. So you need either to look at some estimates that sometimes WHO provides at regional level, at global level, or you can use modeling. Modeling can also help when you don't have the data. Or you can then decide to do some survey or some studies to be able to collect some data. Just taking an example, one country was, okay, before deciding if typhoid is a vaccine that we should consider, we need to know what kind of strains we have in our country. Is it TIFI, para-TIFI, and those kind of things. So they said, for now, we're not going to make a decision on prioritizing typhoid until we get more knowledge about that. And they decided to do some work to be able to collect that data. So that's an example. And I see that Ben, raise your hand. You want to add? Please go ahead.
Go ahead, Ben.
Thanks, Kamel. It's actually not to add, it's to ask you a question if I'm allowed to.
Of course.
We'll take your question, Ben. I don't see any other hands at this point. Please go ahead.
Yeah, I mean, Kamel, based on the countries that have used the tool, and I just wanted to know whether there has been some experience on the role of Secretariat, because you said NITAGs need to drive this. And we know largely NITAG's work is very dependent on the support from the Secretariat. And recent WHO survey shows many countries do not have dedicated Secretariat support. What has been your experience of the countries that have used the tool in terms of the role of the Secretariat, and what can countries expect who want to use the tool and do not have a dedicated Secretariat? Thank you.
So thanks, Ben. And this Secretariat question is key, to be honest, not just for the prioritization, but for any activity of the NITAG. And we've been advocating strong Secretariat for NITAGs for more than a decade now. So our experience for the prioritization, for countries that had a very strong Secretariat of the NITAG, and this Secretariat can be the EPI program, but in some countries it was like a College of Science or university. It depends on the country. Each country has its own way of providing support to the NITAG. When this Secretariat is very strong, the process was very smooth, very easy, because they were used to collect data, they were used to analyze data and to provide those data back to the NITAG members for decision making. So that was easy. In some countries, the Secretariat was there, but didn't have enough human resource. And it was a bit difficult. The way we found is that NITAG members were directly engaged. And for example, we divided the criteria among the NITAG members. So each of them focused on one criteria. For example, one would focus on the burden of disease, and the NITAG members will then reach out to the partners, the hospitals, the Ministry of Health to find the data for the burden of disease, and we'll bring it back to the NITAG. So that's the solution that was used in the countries where there was limited human resource at the Secretariat. And in countries where the Secretariat was a bit limited because they didn't have a lot of experience, because the NITAG was recent or was not quite well supported, the role of the partners has been critical. Like WHO, UNICEF, and others, including NISH, can provide some support to the NITAG to be able to do this prioritization exercise. It can be remote. It doesn't have to be in person. It can be done in remote. And we've done it in a few countries where the support was provided in remote and it worked well. So those other NITAG members, the ex officio, the liaison officer like WHO and others, they are really key to make sure that some support is provided to the NITAG. So that's our experience.
Thanks.
Yeah.
Thank you.
That's a really important question. There is another question on the screen, and I think this was going to be our last question for this round. I really want to appreciate the enthusiasm and engagement. So, Kamel, I think this is also reflecting part of your topic. And please go ahead, and I can add in at the end as well. Thank you.
Thank you, Folake. And indeed, the limitation of the supply is a problem that many countries can face. When you do the prioritization, you may find that, I'm just taking an example, huh? It's not the reality, but an example like HPV is for us the most important vaccine that we should consider introducing in the future. And that's the number one. But then when you discuss with colleagues from UNICEF and WHO, you get the information that the supply is limited and that you will not be able to introduce this vaccine, for example, if you said in 2027, because there is limited availability of the vaccine. So that's why we propose countries to do scenarios. In the scenario one, HPV is still the first vaccine you want to introduce in 2026. And in the scenario two, you are like, okay, if the vaccine is not available in 2026, we then decide that we will introduce it later. And in the meantime, we prioritize the second one that was in the list, let's say, PCV, and we put that one as the number one because the availability is not guaranteed. And then every year, you reassess the situation because sometimes the production then is increased and then the vaccine is available, and then you can decide that HPV now is available. So now let's go back because it was the first. Let's go back to our first scenario and let's introduce that one. So you have to have this information, and UNICEF and WHO are the ones that can provide you with this information. I just saw that CD, you raise your hand. I just want to be, I don't know if we still have time, but any...
Yeah, CD, did you want to support any of the questions previously?
Yeah, thank you, Kamel. Thanks, Fulake. I think the question for NITAC support, it is important. When the NITAC has a question, please, you can open the working group to the experts in the country, but also experts from outside. What is important is that those experts who will be coming, just be sure that they are filling the confidentiality forms and the conflict, no conflict of interest. And you have academics in the countries. It is important to use this academic to generate for you some of the evidence that you are needing to make the recommendation, especially for the new vaccine prioritization. That is really something the NITAC need to be beyond the core members and the secretariat, but open the working group to the others expert in the country.
CD, thank you very much. And just to also complement the issue around global vaccine supply, I believe Kamel mentioned it, that you can actually revisit your scenarios as well, so that over the period of time that you have projected, you can go back and see, well, things have changed, and look again at the scenario that you are either updating or you are changing to reflect the changes in the supply. So with that, I am going to hand back to Kamel for the next session, and is going to actually begin to walk through and show us where some of these tools can be found. We'll be monitoring the chat and taking responses there as well. Please do use the Q&A box as a reminder to put further questions that you have. Thank you.
Thank you, Folake. So let me move to the next session. I'm going to show you the tool itself very quickly. I'm not expecting you to know everything and to dig in everything. It's just a generic presentation to show you that the tool is available and you can use it. So the tool is available on the well-known NITAG Resource Center, where you can find a lot of information for NITAGs. So the tool is available there. The link is there, and the presentation will be shared with you. So you have the link, but you can also Google it and NVIPST NITAG Resource Center, and you will find this link. It's available in English and in French, even if most of you today are English speakers. So the toolkit itself, we try to develop a tool that will help you to do it on your own. Of course, you can get some support to use it, but the idea is that countries should be able to use the tool itself on their own. So the toolkit is really the processes of those 3 steps that I mentioned, and help you for workshop 1, to help you to collect the data, help you to do the workshop number 2, and all those things. So the toolkit is a step-by-step approach, an easy one. I told you there are 9 steps. It's comprehensive, so we gave you all the tools to do those 9 steps. You don't have to use all of them. You can use only the ones that you're interested in. And that's a tool that helps you not to miss any step. So the tool is just a tool, okay? You have to do the work and use the tool for yourself, but you still have to do some work to collect the data, to adapt the tool to your own context. So the tool is composed of 2 things. One is a 35 pages document. 35 pages is a bit long, but you don't need to read the 35 pages. It's just a guidelines for the person who's going to be in charge at the secretariat or the NITAG to conduct the process. It responds to all the questions. It's easy to read, to be very honest. It's really just to help the person who's going to be in charge to know what are the different steps, what is expected, and what tools are available for each step. So on the right side, you see that the tool, in addition of this guideline, contains 12 subtools that you can use or not during the 3 phases, okay? And I'm going to go very quickly through those different tools, and you see most of them are Word, PowerPoint, or Excel sheets, okay? So let me show you directly on the website, and give me 1 second. I'm going to switch window, and I'm going to go on the website. So you go here, you go on the website of the GNN, NITAG Resource Center, and you have the different pages, the different tools, okay? So it's on internet, I'm on internet. So the first one is the tool, the guideline itself, okay? The 35 pages that I mentioned. Then you have tools for different steps. First, terms of reference is to agree between NITAG, between the EPI program, who's going to do what. It's just a list of activities. So if everybody is in agreement, what is the Secretariat doing? What is the NITAG doing? Then you have stakeholder engagement, slide deck. It's a slide deck that is already done, that is very close to what I just presented. So you can share with the Director of Health, the Minister, whoever is interested in the prioritization to understand what it means. Then you have work plan template. It's just to agree within the NITAG and with the Secretariat on the different steps. Like, when are we going to do the first workshop? When are we going to do the second workshop? It's just a work plan that you can use. The next document is the list of criteria and indicators. I told you there are many criteria that you can use to compare vaccines: burden of disease, efficacy, safety, etc. There are many criteria. We shortlisted the criteria here, so you can then decide which one you want to use, and don't use too many. 10, 11 maximum. Don't use more, because then it's complicated to compare vaccines. Then there is a questionnaire. The questionnaire is used during the first workshop for the NITAG members to decide, to vote on which criteria they want to keep, because there are, as I said, many criteria. Which 10 to 12 criteria you want to keep. So that's just a voting tool. Then there is a slide deck that can be used online to present to the NITAG members how the process is happening. There is a framework adaptation that you can use to adapt the process to your own work for the first workshop. There is a data collection matrix. As you said, as somebody asked, there are many evidences you have to collect. So this is just a tool to collect and gather the data for the burden of disease, for the efficacy, etc. It's just a tool where you put all the data. So when you go to the second workshop, you will be able to have all the data in a document. Then this is the Google form. When you're going to compare vaccine for one criteria, again, let's take burden of disease. I'm comparing vaccine A to vaccine B, and I'm looking at which one has the highest burden of disease. You can vote for each criteria which vaccine is the most important one after the NITAG has been looking at the data and has been discussing the data. You make the NITAG members vote so they can rank the vaccine in terms of importance for this criteria, and you do it for each criteria. And then you have a tool here. It's an Excel sheet where you put the scores, and it shows you automatically which vaccine is the most important one. There is a guide, so I should have mentioned a guide to collect evidence, and then a slide deck for the second workshop. So you see, those are just tools that you can use during the different steps, and the tools are already available, so you can then use them, so you don't have to reinvent them. They are already there. So that's what I wanted to present. I just want to mention that there was a mention earlier about one of the source of information, and there is in the tools I just presented, there is one of the tool where you have all the potential source of information for each criteria, and one of them is the WHO compendium, where you already have summarized the data for HPV, hexavalent, RSV, and PCV, and other vaccines will come soon, but those are the 4 vaccines that were added in the recent weeks. So you already have all the data that are available for each disease. You have the burden of disease, the safety, the acceptability, the cost, the market. So most of the criteria you're going to use for the prioritization, WHO did already this, so you don't have to do too much work. You mostly will have just to look at your own data in your own country. And that's a very good tool that I really encourage you to use. Let me stop. I think I'm at time. Back to you, Folake.
So we did have a little bit more time left if you needed it, Kamal. But if not, maybe we can do an integrated Q&A with Akbar. Over to you, Akbar. Thank you.
Yes, fantastic. Good morning, good afternoon. Very great presentation by Kamal. Thank you very much. And I want to introduce myself first. I am Akbar Futuhi, Professor of Epidemiology, Tehran University of Medical Sciences, School of Public Health. I had this privilege that I attended a workshop, a 3-day workshop last year by Kamal, Florian, and their colleagues. And in this 3-day workshop, we learned step by step how to use this tool and implementation of this tool. And the tool is very great. And after that, we conducted the tool in Iran, and we conducted all steps based on the tool and different very useful aspects of the tool. And we developed our scenarios, and last week we presented the result to the Ministry of Health, Vice Minister for Public Health, and the chair of CDC. They endorsed the process and the result, fortunately. And this was a very good experience. The final point that I'd like to make is that the tool is fantastic. It works very good, and you can run it with your own. And of course, I got help from Florian, especially in different steps. But the tool is very great. And interestingly, Kamal, NITEC members were very interested to this, comparing to knowledge to recommendation. They understand it better, and the tool is very great. I hope that people can run this tool in their countries. So, having said that, we can go to questions if colleagues present any question, or participant can raise hand if they have direct question. I don't see any raised hand. Can I ask a question myself?
Go ahead, Akbar. I was even going to ask you a question, but go ahead.
Oh, yes, please. I think that regarding the criteria for addressing the limitation of market limitation, it seems that there are many criteria in those 71 criteria you provided us to choose at the first step during workshop 1. Some of them address this issue. And the problem could be that when we choose, for example, 10 or 12 criteria, it's quite possible that nobody choose those important criteria in terms of market availability, price, etc. And when they want to review the criteria, then NITAC members may say that we need those information to decide. So how can we be sure that all main aspects of information will be presented?
So thank you very much, Akbar, for that question. It's a key question. I would say that it used to be a question mostly for middle-income countries because they are the ones who are paying their vaccines 100%. But it's going to come also a question for Gavi-eligible countries because of the fact that Gavi did not get all the funding that we were expecting because of the difficulties of getting countries to put money in Gavi and in any development at those days. Even the Gavi countries will have to make choices that are based on the cost and the cost effectiveness and the cost impact, all those things that in the past they were not looking at because they were just taking vaccines that Gavi was financially supporting. But now, because of this lack of money at Gavi, there will be a new approach where Gavi is going to give probably those country vaccine envelope, and the country will have to make it happen within an envelope. So they will have to decide also which vaccine they can introduce, knowing that they have a limited envelope of money. So this question is more and more important and will become more and more important for all the countries. We are working with UNICEF and WHO to be able to get more information available for countries, especially in terms of cost of vaccine, but also availability in the future, because it's not always easy, as you know, to know who's going to produce which vaccines in 2 years, in 3 years, because there are like some changes also in the market. So it's not easy, but we are trying to get that, and UNICEF and WHO are really supportive to be able to share more information and to make this information available easily to the countries. So hopefully in the coming months, we'll have more and countries will have more access to those critical data that are now more and more important at country level. Because I mentioned that Gavi is going to give less money, but countries are also facing some difficulties to get their health budget covered because of the crisis, economical crisis that we are all facing. So even the middle income countries will have to do it even more. I hope I responded to your question.
Great. Any questions from participants? Any raised hand?
So I'll take advantage of having the mic, Akbar, to ask you one question because you did the process. One question that always comes is the difficulty to collect data from the country level and what to do when you don't have data for these specific criteria. Any example in Iran where you didn't have the data and you had to use modeling or looking at other countries?
Very great question. That compendium was very great, you mentioned, and we have now 4 vaccines there. In addition, position papers, I mean, the SAGE position papers usually are very great to address many criteria, especially those who are globally important, or when we need global evidence. In terms of national evidence, you're right. In many aspects, we don't have enough information, especially when a disease is not the vaccine for that specific disease is not available in the country. So some criteria is not available for the country. It's obvious because we have no experience from that. Usually we try to extrapolate from other countries in the region. And to be honest, finally, the NITAG members voted based on their sense of the whole evidence they learned. And the burdensome part of this process is collecting evidence. It's very difficult, and it took 3 months, as you mentioned, to collect enough evidence. And usually NITAG members are demanding, we need to know this, that, to decide. And this is a limiting factor of the process, definitely. Benjamin has a question, raised hand. Please, Benjamin.
Thank you, Akbar. This is a question to you, and Kamal could also weigh in. So, in your experience, especially the last phase of the process, where you look at the scenario, we know that vaccination results to impact when the coverage is high. And it's not just about vaccine introduction, it's making sure that the vaccines that have been introduced reach the wider population. And we know, especially in our setting in Africa, there is still quite a bit of stagnation of vaccination coverage. So I'm trying to find out what extent does the country's immunization coverage need to be considered in the process of vaccine introduction. Because you don't want to introduce a vaccine when the basic vaccines, the coverage is still quite suboptimal, because you're going to end up with still suboptimal coverage. Is there some sort of consideration on coverage during the last phase of decision making? Thank you.
Yes. My understanding is that first, in Iran, our coverage for all vaccine is more than 95%. So we have no issue in different parts of the country. But my thought about your question is that the second workshop, and Kamal will correct me, the second workshop has two parts. In the first part, we should observe our evidence. We should rank all vaccines based on those criteria, and then we will calculate mean rank for all vaccines in two axes, I mean feasibility and importance. And finally, we will have three tiers of vaccines based on the discussion we had, that of those pre-selected vaccines, we have three tiers. We had three tiers. And then when the second part is very challenging, and usually it takes at least 1 day, even 1 and more day. You need to sit with EPI managers, with MOH, to see the constraints. This is our recommendation. We thought that these two vaccines should be the first vaccine to be introduced as the first and the high priority tiers. But Ministry of Health should accept. And this part of the process, if I'm correct, Kamal, this part of process is very important, that EPI managers, EPI people are involved, and they will intervene. In the other parts, usually they listen, they are present, but NITAG members will decide to recommend. But this part is very important. It is a mutual activity between these two parts. And to our experience, we changed our mind by their comments during the second day of the workshop. This is my understanding.
So let me add to that. You're completely correct about the idea that after the NITAG members have ranked the vaccine, they have a dedicated session to discuss with the EPI program, to discuss about the programmatic aspects. And at least two other countries I have in mind decided after the discussion to do scenarios where vaccines were postponed. They were like, okay, we were considering to introduce HPV next year, but now that we are listening to you, we think it's better to wait another 2 years, because we need to focus on the routine immunization, and we need to make sure that we are at least introducing, for example, MR, measles, rubella. We should introduce hepatitis B, which are long overdue, they said, in those two countries. We should have introduced the vaccines long time ago. And those will fit in the routine immunization program and will help us also to increase the coverage because of the interest of the mothers and families regarding measles and hepatitis B. So yes, they should consider it. It's very important, and it should impact the scenarios that countries are talking about. Discussion is key in this prioritization exercise. It's not just voting and at the end it's automatic. Otherwise, we don't need humans anymore. It's artificial intelligence. We need the brain of the people to discuss a lot. And I can tell you that in all of those countries where the prioritization exercise was done, there was a lot of discussion, a lot. People fighting, people disagreeing, but looking at the data and then making a recommendation. Discussion is key. Thanks.
Thank you. Greg, please.
Yeah, Kamal, thanks very much for very informative session, and thanks to Akbar for highlighting some of the practical issues. I just had a question, Kamal, in the context of this sort of scenario planning. We're looking at 3 to 5 years in the future. What should we be introducing? And my understanding is that we're looking at the current products that are licensed. So we've got RSV on the horizon, and we've got, vaccine XY that's licensed. What about vaccines that are in phase 3 clinical trials? And a good example here would be, for example, TB. With the 72F vaccine that's undergoing phase 3 clinical trials. In the phase 2 trials, 50% vaccine efficacy, not a bad vaccine given, the extremely high morbidity mortality in Africa. How do you factor that into the process of decision making moving hence in the context of scarce resources? So we're not only talking about TB, we're talking potentially HIV, talking potentially, hopefully, COVID has disappeared, but, phase 3 trials with combination COVID flu vaccines. How do you factor that into this sort of scenario planning? The what if scenario?
So Greg, let me reassure you that in all the countries we've done the prioritization exercise, TB was probably the first vaccine that was mentioned by the NITAG members as the one that they really think is needed in the country. And that's, as you said, because of the burden of the disease in many of our countries. So TB was always mentioned. The thing is that, as you said, depending on the period that is considered, 3 to 5 years, we consider that TB will not be available in the market in this period. We still had a presentation on TB specifically mentioning the ongoing clinical trials, mentioning the pipeline, starting to explain to people that the target will not be the target of BCG. That's another target, and we expect this to be a game changer for the TB outbreaks. But we excluded because there is no vaccine that will be available in this period of time. However, what an important element of the prioritization is that you have to revise it on a regular basis because situation is changing. Let me take an example. If HPV was until very recently it was 2 doses minimum. Now there is a recommendation of WHO to use 1 dose. So that's a game changer, and that's something you should reconsider your prioritization, because if it's 1 dose, it's easier, it's cheaper. So that's why you need to revise your prioritization exercise regularly, because there is a change of recommendation at global level. There is a new product that is available on the market. You mentioned RSV. We are waiting for RSV to be available in vials. It will happen in a few years. So when this vaccine it will be available, then the prioritization should be revised. So we encourage country to annually look at the prioritization and rediscuss it during a session of the NITAG to get any update and change it based on any update that is coming from the market, from WHO, from any other reasons.
So it's not a static process.
Completely. For us, it's iterative. It has to be done on a regular basis. Not the whole process, because the whole process, as we mentioned, needs a bit of work. So we cannot do it every year. It's too heavy. But you can do it every 3 years, 4 years. And in the meantime, you just monitor the situation around you. And if there is anything that changes the prioritization, you should then bring it back to the NITAG and discuss at the NITAG.
Thanks, Kamal.
Thank you. Any other question? What I can add to that question is that, interestingly, this process, Kamal, shows us that there are many other priorities that we missed before looking all vaccines on the table, all criteria. And some diseases, are, as you mentioned, are very interesting for everybody. But when they try to prioritize, even the NITAG members will prioritize differently. And so, as you mentioned, at first people said TB. In Iran, TB is not a big issue. But when they look at the criteria, they change their mind. And yes, Folake, please.
Thanks very much. I actually just wanted to make a comment. I'm a former SAGE member. Where I served on SAGE for 5 years. And I wanted to link in that experience with the decision making that the NITAGs are undertaking. Now, for SAGE, there is a long list with a projection of potential vaccines. And that list is reviewed periodically. And it also looks at which vaccines are in clinical trials, phase 3, which ones have been pre-qualified or in the process. So I just wanted to share that even at the global level, SAGE is constantly looking at a long list and a short list and updating that and revising based on emerging information. So just reflecting that as well, that the NITAGs are also undertaking that process as well.
Great.
I see a hand.
Kamal? Yes.
Akbar, I see a hand from Richard. I think that will be the last question.
Sorry, Richard, sorry. Please.
Yeah, thanks very much. Just a quick question about conflicts of interest and how to handle that within this process. So I'd just be interested to hear any experience of that from Iran, for example, where you've gone through this process. But it strikes me as something important to have a plan for how conflicts of interest will be handled within this, given that this is the kind of first step in prioritizing which vaccines might be considered. So yeah, is it something that we need to think about, and is there a kind of established framework within this for how to handle that? Thanks.
Yes, what we did is before this process, nowadays NITAGs are very concerned about these, and this is the process is conducted by NITAG members. So when they are recruited to be a NITAG member, they should declare the conflict of interest. Is a part of even the maturity tool of NITAGs. So for this process specifically, we didn't check that, but all members before that they declare the conflict of interest positions.
Yeah, just want to add the same thing for the other countries. It was the exact same approach. They use the usual management of conflict of interest of the NITAG. They do it at the beginning of every meeting, asking, is there any new potential conflict of interest? And they go around. So they do it on a systematic way, but not specifically for the prioritization, but they do it for any NITAG meeting. So we didn't put in place a new approach.
Thank you very much. It seems that we are running out of time, and it's time to hand over back to Romandi. Yes, please. Thank you very much, Kamal. Sorry, Benjamin, the program based on the program. Sorry, Benjamin.
No, it's absolutely
Back to you.
fine, Akbar. And just very quick thank you to our speakers and moderators, starting with Greg, Kamal, Folake, and Akbar for sharing the Iranians' experience. We do appreciate that. And of course, thank you so much to NITAGs themselves. We've heard that this process of vaccine introduction prioritization is driven by NITAGs. We as partners, Development Catalysts, WHO, NISH, JSI, and Choices, we committed to work with you and make sure that we support you in all ways possible. Not only in the process of vaccine introduction, prioritization, and optimization, but also in other ways related to vaccinology, and also exchanging of experiences, best practices. And we will continue with this webinar series and ensure that at the end of it all, you are well equipped, at least with the fundamental knowledge to help you in the process of decision making and in the process of new vaccine introduction based on a systematic process using the NVI PST tool. With that, I thank you all, and just to let you know, the next webinar is going to be on the 19th of November. Just before I go to session 3, it's important to mention that tomorrow we're going to have the French session for webinar 2. And then after that, we will give you some time to see how you can apply the knowledge that you've learned. And then we reconvene again on the 19th for webinar 3, English session, the 19th of November. And then 20th of November will be the French session. With that, thank you so much for your participation, and thank you to the partners, again, Choices, JSI, NISH, Development Countries, and WHO. May long live this partnership as we continue to support the work of NITAGs, not only in Africa, but also globally. Thank you very much, and keep well.
Thank you.
Thank you. Bye.
Yes.
Thank you.